All right, welcome. I'm John Schwartz. I'm the Dean of the College of Public Service. Really excited to have you here tonight for this important Vital Voices. This really represents our social work program, which we are very proud of. So at the University of Houston downtown, we are the second largest university in Houston. We're the most diverse, not just in Texas, but in the southern region. And our mission is really to make a difference for our students as future leaders, but also for our community. And so I can't think of a better example than this Vital Voices tonight. So I'm not going to talk for a long time because there's such great content, but the idea is that we're going to be talking about today is suicide prevention. And we are lucky enough to be led by Dr. Savani, who recently did a Fulbright on this topic and is an expert in this topic, and she'll be leading us tonight in our excellent panel. So excited to have them here. And before we bring Dr. Savani up, we're going to show a short video that'll kind of introduce the topic.
Thank you for being here today at this very important Vital Voices session on suicide prevention. It is so good to see so many of you here in person and so many of you online. So before we start talking about suicide, I just want to note that today is September 11th, and I want to acknowledge the friends and families of those who lost their lives in the 9/11 tragedy and in the years thereafter. This is a somber moment for us as we reflect on the countless losses that we have incurred as a nation due to 9/11. So this Vital Voices is in commemoration of World Suicide Prevention Day, which is observed globally on September 10th. So some facts about suicide. Close to 1 million people die by suicide every single year. Suicide is a human phenomena. It is a very complex human behavior, but it has existed throughout human history. As long as human beings have been alive, suicide has existed. And suicide is mentioned in every ancient text, in every religious text, including the Bible, the Quran, the Torah, the Vedas, the Upanishads, Buddhist religious texts, etc. So we call suicide a very complex human behavior. There is no one single reason why people die by suicide. The causes, suicide is very complex, and the causes for why people take their own lives is also very complex. And therefore, simplistic explanations of why suicide happens does not very often do justice to the complexity of the problem. So, some facts about suicide. Approximately 1 in every 100 deaths is a suicide. More than half of all global suicides, like 58% of all suicides, occur before the age of 50 years. So, suicide is a phenomena mostly among younger people in the world. Okay. The suicide rate among men is twice as the suicide rate among women. So many more men die by suicide than women. Globally, suicide is the 4th leading cause of death among youth, age 15 to 29 years old. Suicide occurs in every country around the world, but globally, more than 3/4 of all suicides, like 79% of all suicides, occur in the low and middle income countries of the world. Only about 20% of suicides happen in the rich countries of the world. But largely, most of the suicide research comes from the developed countries around the world. So for every suicide that happens, there are 20 attempts. And suicide and suicide attempts are criminal offenses. And this is a largely unknown fact in the West. And that is that suicide and suicide attempts are criminal offenses in more than 20 countries around the world, which means that when people exhibit suicidal behavior, for example, attempts, they are legally prosecuted, they are fined, and there is even jail time in some countries. Okay? So, when we look at suicide, there are a lot of factors that are very closely associated with suicide. And in suicide research, we characterize these as risk factors and protective factors. So, factors associated with suicide are many times contextual. They vary from context to context, from country to country, from culture to culture. But some factors are universal. For example, mental illness is very strongly associated with suicide. So 90% of those who die by suicide have a diagnosable mental health disorder. But this statistics research for this comes mainly from the rich countries around the world. In the low income and middle income countries around the world, mental illness plays a secondary role. Other factors such as economic factors, family problems, relationship issues, unemployment, poverty, gender-based violence, these are more prominent as risk factors for suicide. Other universal risk factors for suicide are a previous suicide attempt, family history of suicide, prolonged stress such as harassment, bullying, and easy access to means of suicide. Now, risk factors are those things that increase the risk for somebody to take their own life, and protective factors are those that protect people from suicide. And some of the universal protective factors are good relationships with family and friends, community support, involvement in a religious community, limited access to means of suicide, and access to healthcare, access to mental health care. Okay. So the state of affairs for suicide in the world is pretty dire. It's the figures are pretty stark, and you learn all about it today. So what has UHD done to sort of contribute to a solution to this issue of suicide? So what we have done at UHD social work program is introduce a course, an elective course on suicide at the bachelor's level, which is pretty uncommon for a bachelor's level student to go through a course on suicide. So that's what we've done, and we've consistently taught this course over a number of years. We've also introduced a study abroad program to India focused on suicide prevention and mental health, and students going to India this year are currently here. And we've taken students to India, also a number of students to India for a number of years. Actually, this year will be the 5th study abroad program that we are doing. So it's not a whole lot, but thanks to social work leadership, Dr. McCarty, we've made some strides in contributing to a solution for suicide in our little context. So today we are going to be talking for the next hour and a half about suicide. We have 3 phenomenal speakers here who have spent their entire careers on suicide research and suicide prevention. But I want to say before we get into the topic of suicide, I want to make a safety statement, and that is, if suicide is a very sensitive topic, and if any of you feel uncomfortable or triggered or find yourself distressed, please feel free to step away, take time for yourself. You can call the 988 Suicide Prevention Helpline. Okay. So without further ado, I would like to introduce to you our first speaker of the evening. It is my honor and privilege to introduce to you Dr. Anish Cherian. Dr. Cherian is an associate professor of psychiatric social work at the National Institute of Mental Health and Neurosciences, Bengaluru, India. He holds a PhD from NIMHAS and a Fogarty postdoctoral fellowship from the University of Florida. His areas of research interest include global mental health, suicide prevention, and stigma. Dr. Cherian received the Public Health Research Initiative Fellowship by the Public Health Foundation of India to carry out public mental health research between 2015 and 2019. He is a member of the International Association for Suicide Prevention and coordinates the Regional Network for Suicide Prevention for the Southeast Asian region. He also serves as a topic expert for the mental health treatment gap for the World Health Organization. Additionally, Dr. Cherian serves as a member of the Human Ethics Committee of the Indian Institute of Science. He is currently involved in a UK-funded multi-country study on stigma. He is the principal investigator of multiple suicide prevention projects funded by the Indian Council of Medical Research, the Ministry of Health and Family Welfare, Government of Karnataka, and other corporate funders. The research studies include developing a mobile app for suicide prevention, studies on urban self-harm, community surveillance of suicidality, workplace suicide prevention, and youth suicide prevention initiatives. Dr. Cherian has long been involved in supervising doctoral students and medical doctors in the area of public mental health and suicide prevention. Dr. Cherian and the National Institute of Mental Health and Neurosciences will also be hosting our students this year at the Study Abroad program in December. So it is about 4:30 a.m. right now in India, and Dr. Cherian is joining us live from Bengaluru, India. Please welcome Dr. Anish Cherian.
Thank you very much for organizing this wonderful evening. So, as a suicide prevention researcher or suicide prevention worker, it's very important to have this conversation across the globe. Like we have series of events and series of awareness campaigns happening across the globe as a part of International Association for Suicide Prevention and a part of our own initiatives in India and a South Asian region. So this evening, I'm going to talk about the suicide prevention initiatives and suicide prevention, suicidality in low and middle income countries, mostly focusing on Southeast Asian region. I'll be talking, as I said, I'll be talking about suicide prevention work, what we do, and what happen or taking place in the low middle income countries. As we all know, as the first speakers talked about, 79% of the global suicide reported from low and middle income countries. 70, it's a huge. And if you look at the data from my country and China, around 44.2% are reported from our side. It's only two countries reports huge, almost close to half of the suicide reports from these two countries. Alarmingly high, 88% of the adolescent suicides from low and middle income countries. Adolescents or young adults, like 70 to 80% of the suicide globally in the youth, and 88% reports from low and middle income countries. Go to the next slide, please. There are huge challenges we face in suicide prevention, especially in the low and middle income countries. One is that we have a very scarce of official reporting. Though we have, for example, in my country, we have a National Crime Report Bureau, which under the police department, which reports the thing, but it's across the globe, like in the low income middle income countries, there is no proper reporting. Another factor which hinders our work is huge mental health treatment gap. We had a national mental health survey in 2016, which reported more than 80% treatment gap for mental illness. And another factor is like 10% of these countries, low and middle income countries, having a national level or national strategy. In India, we have developed a national strategy very recently. 2022 November, we launched our national mental health strategy. But most of the countries in our region, or most of the national low middle income countries, doesn't have a national suicide prevention strategy. Very less countries, like I think in the globe, I think it's around 40 countries. Through our international association for suicide prevention, we are kind of working with the government and officials and suicidologists across the globe to develop national strategies. And me, along with Dr. Lakshmi Vijay Kumar from India, we are actually leading this Southeast Asian regional network to work with the countries to develop national suicide prevention strategy. And another biggest hurdle for our work in low and middle income countries is low budget allocated to mental health. It's less than 1%. If you look at India's health budget, it's 2%. In 2% in the health budget, we have mental health very low, less than 1%. And another biggest challenge we face is the lack of resources. In terms of human resources, other resources, we have very less. If you take the mental health professionals per 100,000 population, is less than one. And huge stigma around mental health and mental illness, and specifically on suicide. There's a huge stigma around. So generally, people won't come and seek for help, or seek help from mental health professionals or other health providers. Another one, as the first speaker spoke about, there's a slow to warm up attitude to decriminalization. India was suicide was decriminalized in India very recently, 2017. Though we have the law where it's decriminalized, but it's very slow to warm up, and it's still considered, or maybe I think some part of the country or some part of our low middle income countries has been still treated as a criminal offense. And sometimes not in India, but some countries, it's still jailed and barred in the jail. And some of in this context, as low middle income countries have a different cultural context, where we have, first of all, the resources are very low, and issues are totally different. most of the cases it's not mental health issues which leads to suicidal behavior, but in our country it's slightly different, or in our region it's slightly different. In that context, I thought like I'll present to you the low cost strategies which we kind of developed, so from our own work, so that I think I can contextualize and tell you what kind of work we are doing and what works in low and middle income countries settings. We have different pathways which we thought will start working. One is like developing surveillance system. Another thing is like hospital based services, providing care in the hospitals, and developing mental well-being curriculum, as you all have in the curriculum in the social work department. We are trying to develop curriculum for various institutions and various courses, including social work, integrating suicide prevention work in existing systems like in a workplace suicide prevention, or existing systems like in the hospitals. This is it's important for us to integrate, because it's a very easy way to deliver services. Another work, we as a social workers, or as an individuals, we advocacy becomes most crucial, especially the countries like ours, a very low resource settings. Advocacy with the working with the government with the regional organizations or in larger institution, so that we can actually propagate or try to integrate mental health in all the workplaces and other institutions. Go to the next slide, please. Yeah. So in that line, we thought we will develop some self-harm registry and a kind of surveillance system. We did it in different settings. The first one is self-harm registry. What we have done is the current. If you look at the current suicide reporting or suicide related data comes from police forces, the National Crime Report Bureau in India. Likewise, it's in various other countries as well. So what we tried in this is like the self-harm registry in general hospitals. As a pilot, we have started in few hospitals. So all the self-harm or suicide attempt cases which reaches to emergency departments would be tracked and provided intervention. So I'll come back to that point a little later, the intervention part, but I'll talk about the surveillances in various other settings. Another setting which we are also trying is suicide surveillance team, which is what our intention is to have a surveillance team within a village, like in each village, each county or the province will have their own self-harm surveillance team. In the village, what we are working is like we will have 10 to 15 people who will be trained almost like a gatekeeper in providing brief intervention, identification, brief intervention, and link them with the appropriate services. So we have we are doing this pilot work in one of the districts. So we have around 50 villages in that in district. So all of them will be trained to identify and track and have a good follow-up within the community, so that there will be community surveillance team. Another work which we also have is suicide prevention action team, which we closely work with a couple of industries, organizations, where we identify the key stakeholders, key people who can actually work as a action team, where the employees or the in the organization or the institutions. So they work as the peer leaders. Maybe I think they can the people who are actually influential in that organization, who can actually act as a suicide prevention action team, so that they can early intervention or early identification refer to the mental services available within the locality. And we also involved in training huge number of gatekeepers across our country, so that I think what the intention is to have more and more people involved in suicide prevention interventions or suicide prevention work, So it's a gatekeeper training, as you all know. It's a very low cost, or it's about 3 hours. We train them on various factors, risk factors, protective factor, how to identify, how to provide brief intervention, how to link them with the services available. Go to the next slide, please. So another work which worked, or we piloted now, and we are going to scale up to other part of the Karnataka, is the hospital-based services. The hospital-based services are like, what we do in this work is, it's an emergency-driven intervention at general hospitals. We call it as USHS, Urban Self-Harm Study. We piloted this in 5 general hospitals over the last 8 months. We had around 2,521 young people, or largely young people. 70 to 80% of them were young, like below the age of 30. So we our team, they visit emergency department to talk about emergency department. The context is totally different. You might be thinking of the emergency department in your country, but the emergency department is any here is emergency services. We don't have a most of the hospital doesn't have a department per se where you have, but it's more of a casualty services where people will walk in and seek the help. So in this group, we had around 2,521 from last 9 months. So they reported them largely young people. And commonest method used were poisoning or tablet overdosing. It can almost 80% were either poisoning or overdosing. So if you look at the gender differences, like it's almost nearly same. So and we provide them with the brief interventions, lethal mean counseling. We sit with them and make the safety planning. It's like when I say that we do provide the brief intervention, is most of the time it's a crowded casualty or emergency services. It's like crowded, and it's literally crowded like in a market. You'll have hundreds of people will be standing, and the social worker or psychologist provide this intervention in the bedside. Maybe I think you need to stand, and there won't be any sitting arrangement. You need to stand closer to him and talk to him, build the rapport within this short span, because we don't have much time, because people keep moving, and provide them with the safety planning and lethal mean counseling. Then we also did one work is like we have provided them with the contact-based follow-up, like after the discharge, week after discharge, 2, 4, 8 weeks, 3 months, and 6 months. We follow them over the phone, and in case of any emergency, they can actually reach out to us. We had a separate phone number for each hospital, and we were there for them. After 10 months of our work, what we realized is the repeated attempt has come down drastically. Out of these 2,500 people, we had 9 people who had reattempts. It's drastically reduced. The number of reattempts were reduced, and we lost 2 people. They had chronic mental illness, and but I think we could actually prevent repeated attempts and death by suicide. Another work which we also involved, and we thought like it will be very important for low-income countries, integrating our mental well-being curriculum in various courses, so that I think we can actually have more and more people involved in suicide prevention work. One work which we piloted now is mental health literacy module for school teachers, because there's one group of people who can actually involve easily, and very motivated bunch of people who are teachers, so that they can actually identify any kind of suicidality within their school community. So, and refer to appropriate services. We have a district mental health program in our country, and most of the neighboring low-income countries as well. And another thing, what we thought was a suicide literacy program. for the college students, which is a video-based program. We thought like young people would like to have more and more interactive methodology. So then we thought we'll video-based and very interactive kind of interventions. The other work, what we are actually now tested, like your university, like we also developed a suicide intervention module for professional social workers. It's the master level program. We thought like to introduce that program in across our country, not just restricted to our district or our state, but we are trying to develop this and work with the higher education department to integrate this within the our curriculum. This is a elective module for social work students. And we also thought like responsibility reporting very essential. Therefore, we thought we'll develop a curriculum for professional social work, media students or journalism students to report responsibly. This also be like it's a doctoral program which will be completed now, and we are thinking of working with the higher education department to integrate this module within the journalism courses. And we also developed a program where suicide prevention module for primary care staff, which includes doctors, other paramedical nurses, other people in the primary care setting. What we realized is like most of the time, primary health centers are the only health centers or health providers available in the village or in the regional. So there won't be any private sectors, or all the private sectors are based in urban cities. Most of the time, these primary health centers are run by the government, and we thought most of them will be reaching here. So training these mental primary health care providers are very important, and we initiated this work. Now it's going really nice work, which we thought like will be essential for low and middle income countries. We also thought we'll have people who can actually expertise or little more in depth or trained in providing services. So we initiated certificate courses on suicide prevention and mental health promotion for people who are actually from the behavioral science background, that is like psychology, social work, or mental health, the other mental health trainees, which we initiated last year. And this is a 3 months program, and it's in-house. So initial 1 month will be orientation, and we will take the theory classes, and subsequently 1 month in emergency department. They will be placed with emergency department to work with the people who are actually self-harm and suicide attempters who reaches emergency department. They provide services there within the hospital, and they also work with our community and workplaces, so that I think they'll get an overall orientation in suicidology. Go to the next slide, please. And one other important work, what we thought was integrating our suicide prevention in existing systems. In that line, we thought the very cost-effective method is working in the workplace suicide prevention. And we initiated this work in two major industries in India. The important or the essential thing is like the workplaces will have huge the manufacturing industry. What we work is almost 16,000 people work in that one organization, and another one is large organizations. So integrating, they have a very good health system. Most of the time, mental health systems or mental health things are ignored, but health system, they all of them will have a very good health system. In that space, integrating mental health is very important, and plus it's easy to integrate. So what we do is we do brief intervention, follow-up, and referral services. In last 1 year, we worked with around 700 employees, and we had people walking into our clinics within the health system. So around 60 of them for self-harm and other things. And one important result what we have is like there's no report of repeated attempts in this organization. So there is a system. If you integrate systems, it's cost effective because you don't have to invest so much. At the same time, it's within the workspace, so they just walk into our mental health center, and we will work with them, and anytime. And then we also have telephone based intervention, so we are available for them. That's one very important work, which without much expense and cost effective method, workplace suicide prevention. Go to the next slide, please. And we most of the countries in low income countries have helplines for various health related things, not necessarily suicide. We don't have a suicide prevention helpline in our country, nor in my neighboring low middle income countries as well. So what we have done, we are doing is like we train the people who are in the health counselors, who will be trained to provide the suicide prevention or suicide crisis call. So the most of them are trained, so that in case these helplines also get sometimes suicide related calls. So they kind of train how to talk to them and how to work with them, and in case of any no further interventions required, refer them to appropriate services, especially the district mental program. In India, we launched a Telemanus. Telemanus is a national helpline for mental health and other, including suicidality. But we kind of providing a comprehensive services there. But we thought we'll train all of them in providing suicide or crisis calls as well, attending crisis call. And another important thing is capacity building of key stakeholders. It could be employees, it could be students, nurses, or community health workers. We kind of work with all these groups, so that more and more people are trained in delivering interventions. If you look at some of the numbers, I think last couple of years, we have trained more than 8,000 people who are actually volunteers who can provide gatekeeper training. So the intention is to have more and more people who get involved in suicide prevention work, and kind of propagate that suicide prevention is not health department's work alone, or one department, one individual, or one institution's work. As a community, so we need to provide, because the number of suicide reported from low income countries is quite huge, especially young. So we work with the colleges and organizations which younger people are working. So it's easy for us to train, and these young people go and involve in the community services largely. Go to the next slide, please. So we in that context, we these are the work which I presented was like in some of the, for example, the health, it could be one workplace or a hospital. But what we thought was we should have a comprehensive approaches. So what we done was like we selected district where we can actually provide most of the interventions and see whether suicide rate is reducing. Go to the next slide, please. We launched a comprehensive community-based approach we call Suraksha. Suraksha is a safety net. So if you're aware of our World Health Organization's Live Life framework, we're trying to integrate the entire component in a district and see whether it works or is it cost effective. So we launched this in last February to have a model developed in our country, so that we can actually work with other low and middle income countries, especially in the Southeast Asian region. So we have 6 work packages, or 6 component in this. One is the community-based surveillance team, which I already mentioned in the surveillance network. So what we have done is like each village will have a community-based surveillance team. We will train them. It will be around 20-25 people, anything between 15 to 25 people. who are identified from various walks of life. Like it could be people who are working in health, it could be people who are in the education system, or farmers. So various. There is no bar in of education limit or anything. But whoever is interested, they work as the gatekeepers in the village, so that they can identify. We also train them in providing brief intervention, so that they can also provide some brief intervention, talk to them how to communicate to these people, individual who are actually done self harm or suicide attempt. So we also, as you might aware of, ours is an agrarian economy. So if you look at not just India but across most of the South Asian region or low middle income countries, um, so having a centralized storage of pesticides is very important. What we are planning to do is we will have each village will have a centralized storage where pesticide bank. The people can actually keep the pesticides in that storage place, and whenever is required, they can actually take it from and use it for their farm. So, which is a very important strategy as per the WHO, and some of the low-income countries in Sri Lanka, we have actually tried this, and it's become very important in reducing access to mean, because if you look at our own hospital data, uh, close to 50 to 60% of them were using some form of pesticides or poison overdose or tablet overdosing. So they thought like having this centralized storage is very important. And we are also thinking of and initiated as an extension of hospital-based service. We are also trying to provide brief intervention for self-harm and suicidality. All the hospitals in that districts, like we will have mostly government-run hospitals, like at the district, at the province, that is taluk, and at the village or village level, we have primary healthcare centers, so that we can actually track everyone and provide brief intervention and do a follow up, so that it's like it becomes a part of the routine health system. And which also WHO also says like we should have a school based program. So we kind of having intervention for school teachers as well as students. So it's kind of a comprehensive program where within the school we are not just in training but also like integrating a healthy atmosphere within the school. And we are also trying to work with the media, training, as well as engage with the media personnel, so that they can be involved in our work, as well as we can actually help them to provide the work with them, so that then they can actually report responsibly. What we do is like whenever we see any news reports on suicide, and we call them or email them saying that how to kind of provide right information, or what are the things which we need to do while writing the suicide content. Another work is what we realized is like is awareness building. Like we have because stigma is quite huge, people doesn't come and seek help. So we use social media platforms and other platforms where we can actually provide informations, keep sending flyers, brochures and short videos, so that then people can actually have awareness, so that they can initiate or they can actually seek help from the professional services available within their locality. Move to the next slide, please. Another important program which is very cost effective is occupational well-being approach for suicide prevention. What we realized with the organizations what we work with is they have a very good health system. So what we negotiated with the organization that not just suicide prevention, most of the organization won't be interested in providing only suicide prevention, because they won't acknowledge there is a suicide or mental health thing. So we kind of contextualized, or we said it's more of an occupational well-being. So providing suicide first aid, training programs for all the employees, mental literacy training programs. We also integrated life skill education, financial literacy, because young people are joining new industries, so providing financial literacy training, reproductive health training, because young adolescent girls joining these organizations as employees, so that we thought we'll have the reproductive training as well, and life skill educations, and substance use abuse management. We realized substance uses various form, alcohol, other substances, and including behavioral addictions are increasing in this organizations or in our country. So we thought we'll have that component as well. And we also work with the organizational heads or human resource department to have recreational or leisure time for the employees, which in turn will reduce stress and work-related issues, improved work-life balance, improved occupational well-being, increased productivity, in turn, which reduces risk of suicidality in the employees. So it's a very cost-effective method, so that we don't have to have a separate department. We will have a couple of people who are working this organization in the occupational well-being project. Go to the next slide, please. So another important work, especially in the lower middle income countries or higher countries as well. So the working with various organizations or advocacy for the advocacy. In our region, what we have is regional coordination, so that all the countries have national strategies, national suicide prevention strategy, and involved with the various colleges and institutions and organizations to have suicide prevention strategy within the organization. And we also have work with the policymakers. That's one important thing, was educating the policymakers and work with them, have so that I think they can actually have good policies in our region. Go to the next slide, please. To conclude, suicide is a very major public health concern, especially in low middle income countries, where we report close to 80% of the suicide reports from low middle income countries, which requires comprehensive suicide prevention strategies. What we found was, or what we realized is, strengthening existing programs can be cost-effective and approach to suicide prevention. So integrating with the existing system is also very important. Implementation of suicide prevention in the community requires multi-level collaboration or multi-level interventions, and collaboration with various stakeholders, not just within the country, within the region, maybe I think working with various developed countries as well. And it's a very comprehensive approach. We should take a very comprehensive approach. Go to the next slide, please. With this, I end my presentation. I thank all my collaborators and in the region, because we don't work just with India. All this will be with the various countries across Southeast Asian region. Thank you.
Thank you so much, Dr. Cherian. Thank you. Dr. Robin Gehring is a professor of social work and director of the Center for Mental Health Research and Innovation in Treatment, Engagement and Service, MH Rights. The mission of MH Rights Research Center is to improve the lives of individuals managing mental health issues through research, education, and clinical interventions. Dr. Gehring's research focuses on improving the mental health outcomes of adolescents and young adults with serious mental illnesses and their families. His areas of research expertise are schizophrenia spectrum disorders, depressive disorders, and suicide intervention. Dr. Gehring's work focuses on engagement with mental health services, including culturally informed adaptations of empirically supported interventions. His research collaborations nationally and internationally concentrate on innovative strategies for treatment engagement, addressing mental health stigma, and facilitating service utilization. His research continues to focus on developing and testing interventions, improving treatment engagement, service access, and utilization for underserved populations. Dr. Gehring also holds a clinical faculty appointment at the University of Texas Health McGovern Medical School Department of Psychiatry and Behavioral Sciences, and he serves as a board member on the Board of Trustees for the Harris Center for Mental Health and IDD. Please welcome Dr. Robin Gehring.
Thank you. Hey guys, how you doing? I'm tired. It's been a long day, but it was wonderful to be here. The area of suicide really doesn't get enough attention. And I'm glad that you're here. I'm glad that the University of Houston Downtown has put on this event to really bring attention to this important issue. And they say you shouldn't go after a good speaker or certainly before another good speaker. I know Jennifer, Anish was brilliant. Nice to hear and see him again. And I know Jennifer is going to put me to shame. So I almost feel like I should stop now. But I got that monster truck rally introduction in the beginning and I was really excited by it. So, all right. So I was going to talk a little bit on what are we doing. What we are doing is just not working. And where are we and what we can do kind of now. That's a bit of where I was going to focus on. I wanted to give you just a sense of what things look like here in the US. So the CDC released a really brilliant series of study and report that came out and said between 1999 and 2016, suicide had significantly increased across the US. In fact, it had increased in every single state except Nevada, which decreased by 1%, so it really doesn't statistically count. 30% of the of increase were in more than 50 states, 50% of the states. Which should lead the thought is, how come things are getting so much worse? Well, thankfully, since 2016, I say that with a bit of condescension, things continue to get worse. We generally look at both health and mental health issues on ratings per 100,000. Is this better if I go like this? Can I hold it? Can I sing? No, like I'm wanting to sing now. Should I sing? Okay. All right. I don't is this working? Yes?
Hello, can you hear me? Okay, so I guess you gotta hold it really close to your lips.
To your lips or mine? All right. We generally measure things per 100,000. And so what we're seeing is suicide for a very long time has been stagnant in the US. And this increase has started, as I said, for about 30 years. In 2016, we saw it as 13.2. It kept increasing until 2018, and then there was a drop in 2 years, which was phenomenal, except it's been followed by an increase again. And if we looked more closely at the drop, we're kind of thinking that it was a 5% decrease followed by a very significant increase. How's this? I could talk louder. No, it won't last. Okay. And then the important thing is since 2022, it's been a 10% increase in the last 2 years and a 5% from the previous high. Again, things keep not getting in a good place. Here are what stats look like from 21 and 22. These are the last recorded years that we have. It's provisional data. And overall, you can see we're dealing with about 50,000 deaths in the US every single year due to suicide. That's a small city. The increase has been about 2.5%. And we've seen the increase at 2.3% males, which are astronomically higher than females, but we've seen a 3.8% increase in females. Again, a concerning trend that we're seeing that move up even more. If we look at it across general race ethnic groups, we're seeing that the increase has been in all groups and not necessarily in just one. And if we continue to look through the ages, what you'll see is the ages have increased in each group except 10 to 24-year-olds. This one area has decreased, which we can speak to a little bit later. It was nice to see. And that's only over this last 1 year. So every 22 seconds, someone in the US attempts suicide. Almost every 11 minutes, someone dies by suicide. So we've been here for 5 suicides. 54% of Americans have been affected by suicide. I would argue that number is probably higher, but this is what the study reports. This increase is despite major improvements in the recognition and treatment of depression and other psychiatric disorders, the introduction of safer, more effective psychiatric medications, and more novel and effective evidence-based psychosocial interventions, and the improvements of overall access to mental health services. This study was presented almost 20 years ago. It's dated now. We have these improvements. They continue to get better. The numbers continue to rise in spite of that. So my question is why? Why are they continuing to rise? We've been focusing on these 2 people standing on the water, that's my analogy, for a very long time. But if you can see, there's a baby in this picture. You can see the head on the top above the trees. It's in the trees, and then the arms and the legs and the very back is the coastline. Often we're missing some of the larger, bigger pictures. We're trying to focus on the individual characteristics and not the larger events that might be fueling much of what is going on. So for an example, they do this survey, youth risk behavior survey, every year. I've done it for years and years. It's a brilliant survey. They ask thousands of young people every question you can imagine, from suicide to sexual activity to sleeping behaviors. And these are some of them on suicide. For those that have attempted suicide in the past year, 13% of females. That's about 1 in 8. You go into any high school and count 8, and you'll have hit one of them. 1 in 8 have attempted suicide. And for males, it's 1 in 7, about 1 in 14. These aren't good numbers, and they have grown. But this is the behavior of an attempt. So let's look at it in a slightly wider lens. Who's planning it? The idea of planning a suicide, in the last year, 24% of females, high school students, 24%, that's 1 in 4, are planning their death. And 1 in 12 males, 1 in 8. That number is a lot bigger. But let's take it a step even bigger. Who's even considering attempting or ideating? What do you think? Ideation towards suicide. 30% of female students and 15% of male students. That's almost 1 in 3 females. Imagine walking into a school and saying, okay, a third, and yet we don't talk about it. We don't deal with it. We're not focusing on it. And if we looked at youth that reported experiencing persistent feelings of sadness, that's not just mild feelings, persistent, ongoing, day by day, or hopelessness, which are the core elements of depression. 57% of female students and almost 30% of male students. If we so focus on the death of suicide or the attempt of suicide, what we're missing is these larger pictures. If you would want to know if this different in different ethnicities and race, of course, there's some differences. But what you'll see in the 10 years that this graph shows is a distinct increase in all of them. So when we're not doing well, at least we can say we're consistently not doing well for everyone. For adults, 1 in 5 adults describe their own mental health as only fair or poor. That's 1 in 5 adults. So I want us to start thinking less and maybe doing more. So there's current prevention programs that work. We're going to hear from Jennifer about the brilliant work that she and others do, and it is awe-inspiringly brilliant. The hotlines, the text lines, crisis lines, the warm lines all have an effect. We know there's media guidelines around reporting suicides, which have helped. We know there's school education programs, many of which are quite effective. There's efforts to limit firearm access for people who are at risk. And there's other programs, countless programs beyond this more effective ability to diagnose and to treat various conditions. All of these haven't made a significant impact in lowering the suicide rates because we've seen they keep rising. Now, I will say maybe they would have been twice the amount had these programs not been in place, or 3 times. So I'm not belittling or demeaning the brilliant work that's being done. What I'm saying is it is not enough. So why have these programs not stemmed the increase? Well, a lot of contributing issues are just ignored or minimized. We focus on the individual. We don't focus on the larger environmental issues. We're focusing on the act of suicide, not the thoughts and ideations and what's behind it. We do not address access to means very well, although we know that's very effective. We're not very good at understanding and dealing with the impact of cluster suicides. A lot of research is not as vigorously investigated as we would like to think. And many of the interventions and programs are centered around young females because we're not getting enough young males into them. Although all of these have seen some improvements, and we've continued to focus on actions and behaviors rather than the underlying issues. So suicide, if it continues to remain in the shadows, the numbers will continue to increase. The stigma behind suicide and mental health is awe-inspiring. And individuals who are experiencing these, who are thinking about them, don't talk. When I go to high schools and they say, what does someone who's suicidal look like? I say, you, me, half of you in this audience. But they don't want to see it. They don't want to. I've had principals in school territory said, maybe you shouldn't talk like that. And my comment is, I think young people can hear the truth. Can adults? We need to be careful with the siloing effect. Keeping outpatient and hospitals and religious groups and where other wellness centers can be of assistance, they're all isolated and less working in conjunction with one another. Systems view suicide as a liability. It is often better not to assess. When they've done studies with doctors who just recently diagnosed someone with depression, they said, would you assess for suicide? 97% said yes, and about a third did. For good reasons, they don't look like suicidal. If you're wondering what someone who is suicidal look like, all of us. You can't say that there's a type because there's not. We often ignore these underlying risk factors. There is a lack of training. The fact that Dr. Savani talks about a program here, I know she's spearheading that. It's because she's brilliant. But the simple truth is 10 years ago, less than 2% of graduate programs in social work had a program or a class on suicide. More than half received less than 2 hours of training. 93% of social workers will work directly with somebody who's suicidal. Tell me how this is not helping the situation. And there's education in general. The education system, families, parents. We just don't know. Parents in one study said, oh, we would know if our kids were suicidal if they were distinctly suicidal. Less than half knew. Their own kids. We don't educate very well when it comes to the large population. So this is suicide. The numbers keep rising because it's easy to keep in the closet. I'm going to suggest that we tear down the veil and let sunshine in and start actually working on dismantling those larger issues. Because if suicide is dealt directly, it's just an issue that we know can be effectively treated. And it does come down to whether we're willing to have those conversations all the time, regularly, and remove the stigma from it. Thank you very much.
Thank you, Dr. Gehring. I'm sure some of you have questions. Please write them down. We are going to do a question and answer session in just a few minutes. So, our third speaker for the evening is Jennifer Battle. Jennifer Battle is the Vice President of Community Access and Engagement at the Harris Center for Mental Health and IDD in Houston, Texas. Jennifer is proud to support Harris County and its surrounding region's mental health by overseeing operations of the National 988 Suicide and Crisis Lifeline for 49 Texas counties, 24-hour crisis lines for 7 Texas local mental health authorities, as well as the full behavioral health and IDD access hub for the Harris County. Lucky for us, Jennifer has taught at UHD for a number of years. Jennifer led the development of the first of its kind in the nation 911 behavioral health co-located response system in partnership with the Houston Police and the fire departments and the Houston Emergency Communications Center. Jennifer's team offers a robust mental health and suicide prevention training portfolio to individuals, universities, businesses, faith communities, and nonprofits, as well as coordinates and delivers information and awareness about behavioral health in culturally appropriate and community-centered ways across the country. In addition to these projects, Jennifer serves in several national roles, including the immediate past co-chair of the steering committee for the National 988 Suicide and Crisis Lifeline. She also serves on the Clinical Advisory Council for Crisis Text Line, the board of the National Association of Crisis Center Directors, and the board of Texas Alliance for Information and Referral Systems. As a proud alum of the University of Houston, both as an undergrad and through the Graduate College of Social Work, Jennifer teaches courses through the GCSW in partnership with the Nonprofit Leadership Alliance and gets great pleasure from seeing her former students do amazing things in the community. Please welcome Jennifer Battle.
And it's so awkward to hear yourself be introduced. You're like, what? That's me? Stop it. So I'm trying to find my slides. Let me tell you about the day that that report came out that Dr. Gehring just talked about. That report came out within, I want to say, just maybe a couple of weeks of the death of Anthony Bourdain and Kate Spade. I have been accidentally working on suicide prevention for almost 30 years. So I didn't do it on purpose. It just sort of ended up where I was. So my career of doing suicide prevention work was basically that article. And I had already had my tears about Anthony Bourdain because I loved all of that. I had already, informed my staff anytime there's kind of a celebrity or, public figure suicide, we talk about that because we know we're going to get bumps and calls. And then the report came out. And y'all, I laid down on the floor in my office, full out, flat on the floor in my office. I closed my door and I cried. Because there's nothing more humbling than this moment where you feel like you've poured all the stuff that you have, your social work self, into the work. And then you feel like, does it matter? Does the work that we do matter? But as good social workers do, I had my little cry, pulled myself back up off the floor, opened my door, walked into my call center, and listened to my people. I'm going to cry right now. Listen to my people do the work that we do every single day, which is to do our best to be there and be whatever somebody needs in the worst moment of their life. And I believe there's a couple things behind that article or that study. I believe that as a nation, we are doing better at identifying suicide-related deaths. I believe that our medical examiners' offices are learning to not give in to stigma around how to report those deaths effectively. So I do believe that there's some of that happens in those reports. I do believe the numbers are rising. But I also believe that there's some other pieces involved there as well. And I 100 million, 1,000 billion % believe that those numbers would be way higher if we weren't all doing the work that we do every single day. So that's my story about my feels. And it's okay to cry, y'all. Like, it's all right. That's part of it. So, and again, I know we're here a little late and I appreciate y'all. And I know that this is a hard topic. I'm going to give you a couple more pieces of like bad news, but then I'm going to go to good news. But I think it's important because we've heard from world perspective, we've heard kind of US perspective. I wanted to tell you a little bit about what's happened here, like in our neighborhoods. So we know that right here in Harris County, there's 230 some odd zip codes in Harris County, and 204 of our zip codes had at least one suicide death last year. This is really an important piece of information for us because, as you've heard us talk about, suicide is not an issue that's specific to one population, one neighborhood, one community, one group of folks. I loved what you said, Dr. Gearing. Like, what does this look like? It looks like us. And I think that that's a critical piece as we go out and do this work, is that this is everyone in our community, right? This is not just one place. However, with that being said, when we talk about some of the other things that you've heard too, when we talk about social determinants of health and we talk about, what are some of the reasons that are happening, suicide is not specific to a mental health diagnosis, y'all. Like, suicide is a social justice issue. So when we talk about what is leading people to have the worst day of their life, it's because they can't feed their kids. It's because they can't access healthcare. It's because they've been chronically bullied and oppressed and, victimized by white supremacist systems. So that is, I mean, it is true. Like, so we have critically have to acknowledge that as part of the work that we do every day. And we can't medicate suicide away. If we could, we'd be seeing a difference in numbers, right? This is a work for all of us to do. So there are some neighborhoods in our communities that have harder times just going about regular life, right? And so we do see some neighborhoods that have higher rates. We had 4 neighborhoods, y'all, in Houston last year that had more than 10 suicide deaths. I mean, that is...
Can I ask a question?
Sure.
So, of the 26 zip codes that did not have a suicide, were there any common characteristics? Number one. Number two, of the 4 zip codes that had more than 10, were there any common?
Those are a great question. So, and if my agency had a research department, I'd be able to answer that question, right? Because you know how I got this data? I had reports from the medical examiner's office, and I sit at my desk. I cry again, because that's what I do in my office, apparently. Because it's hard. This is, every line on these reports is someone's family, is someone's loved one. And I treat that with great regard. And I have a list of questions about a mile long. Thank you for asking all those. And I literally sent an email to one of my team going, gosh, I really wish we had a research office, because there's a lot for us to learn from this data. But the answer is yes, there are. And I'm going to tell you some things, but I can't tell you specifically these. I have 10 zip codes specifically that I work with, and I can answer those in just a second. So, that was tough, y'all. So thank you for sitting with me, but I just wanted you to really kind of have a minute to let that sink in, and that's why it's so critical for y'all to be here. Because it's one thing when we talk about world, right? Like, oh, wow, world, that's far. It's one thing to talk about US. Oh, US, that's big. But no, these are our neighbors. right? Like this is us. Like these are our people here right now. Like this is something that we can think about. So what are we doing? Because I can't just cry every day. We got to be doing the work. So I have a couple programs I want to tell you about. So one of my programs is called Healthy Minds, Healthy Communities. And this program, we applied for some federal dollars, American Rescue Plan Act dollars that came out after COVID. And you got to be on our list of this project if your neighborhood had pretty bad stuff happen in it. So it means that it had higher levels of impact from COVID, which means deaths and hospitalizations, the highest number of suicide deaths, and the lowest connectivity rates to programs at the Harris Center, which is the organization where I work. We know we're not the only game in town, but we are the provider, one of the largest providers of public mental health services in the country, the largest in the state of Texas and the largest in the community. So it's still a pretty good reflection. And so we do a lot of things that you heard, very similar things to some of our other speakers about what are the interventions are kind of what they are. We know what works. We know what's evidence-based. Well, we sort of think we know it works. We can always do better. But there are some things that we know that we really want to focus our time and energy on. And so for this, the 10 communities that kind of fell to the top of our list are here. And so you can see what some of them have in common. We're looking at straight up 45 north. And then we have Pasadena, which is kind of down southeast. Then we have Sunnyside South Park. And then we have this really interesting situation happening in Katy. And this is on our list because this is high income white men with guns. And which is, if you remember Dr. Gearing's demographics that you saw, that is the highest number of suicide completions, in the U.S. And that is 100% mirrored right here in our neighborhoods, which is also why it's important to point out that there is no specific demographic. So we have to figure out ways to serve everyone. However, as a provider, again, from a social work perspective, every single one of these neighborhoods requires a different type of support because every neighborhood is made up differently. And so we have, and it's actually 3 of these neighborhoods are kind of split. They have sort of half Spanish-speaking Hispanic population and half African-American, but about 6. So those neighborhoods are really, 3 of them really equal 6. So we really have more than 10 neighborhoods. And then about 60% of our neighborhoods are Spanish-speaking bilingual, which is really important information because there is not a lot of good evidence-based supports and interventions that are created from the community, by the community, linguistically appropriate for the community. So that is something that we're working on also. So what does it look like, y'all? This is our work. This is what we do. We go hang out in the community. We're using a program, something like community initiated care, very similar to what you heard Dr. talking about earlier. We go, we hang out, we build trust, and we hope people keep inviting us back. More people come. The next time we hang out, we build trust, more people invite us back. We come, hey, do you want to come to these trainings? Yes, okay. We show up. We're nice, we feed people, and then people keep inviting us back. But true community work, true community-led work means that it takes time. It means it takes time because we have to build the trust. And it's not me, by the way. I don't look like most of the neighborhoods that we're serving for this project. So the people that work in our project we try to hire from the neighborhoods because we want people to come. So the other thing that we do is we do tons of training. You heard us talk about that. We go anywhere, everywhere, all the time. So any place that would have us out, we're there. We have about a dozen different trainings in our portfolio, but we have several that focus on suicide. And I have some flyers out there. So if you are with a faith community or a business or some other school and you're looking for training, grab one of our flyers. And we're happy to talk to you. We have a couple opportunities that are coming up this month for free. So if you're looking for things to do, in addition to all your other things that you're doing, like going to school, please feel free to check this out. We're doing a free mental health first aid next Monday at our office on Southwest Freeway. And then the following Monday, we're doing a free safe talk. So you are welcome to attend either or both of those. So the other thing I just wanted to talk briefly about was 988. Anybody heard of 988? Okay, so some yay, some no. So did anybody heard of National Suicide Prevention Lifeline? Okay, so the old number was 1-800-273-8255. So are you going to remember that in the middle of like the worst day of your entire life? Probably not, right? So we, a couple of years ago, decided to shift this over to trying to make it more in line with other 3-digit numbers that people would call whenever they're needing to remember something quickly. So we landed on 988, and 988 went live last July. The 1-800-273-8255 is still there. It will never go away. So if you have brochures or things or it's programmed to your phone, use it. Right? We still answer it. But as we move forward, we're trying to move to this number. So what happens as social workers, y'all, it's really important that you know how to use this resource. So if you've never called, call. It's okay. Don't pretend to be in crisis or anything. Just say, hey, I was at a presentation. Jennifer told me to call, check it out. So I just wanted to see what happened. And it'll be cool, right? So, so you call because I want you to know what it feels like to call and what it sounds like. Because when you're sitting with somebody who needs help and you're preparing them as part of your safety planning interventions, then you're going to want to know how this works. And guess what? You can also call with a client. So if somebody's in your office or you're in a church or your faith community or you're hanging out with your friends, somebody you know is having a tough time, just be like, hey, I heard about this thing. Let's just see what happens. And you can call together. So it's a great thing to have. So it'll say, hey, you've reached 988. Then in Spanish, it will say, if you'd like to speak to somebody in Spanish, press 2. If you are a person who identifies as a veteran or somebody with military service, you press 1. It takes you to Veterans Crisis Line. If you identify as a person who's LGBTQIA plus under 25, press 3. We have a wonderful new partnership with the Trevor Project for this. This is brand new, y'all. First piece of legislation that's ever been passed in the United States unanimously that includes LGBTQIA language. Big deal. So I'm really proud of that. And then it'll say, otherwise, stay on the line. And then if you stay on the line, then it'll connect you to the center that is attached to whatever your area code on your phone is. So anybody in here have an area code that's not a Houston area code? Of course you do. It just means that your number will still be answered. It just might be answered somewhere else. And so, which is fine because about 80% of the calls that we take, they don't need anything except us. Yay. They just need someone that's nice, that will listen to them and be, empathetic and caring and non-judgmental. And so if at any point in time that call needs some sort of referral, we all know each other. We're all friends. So they'll connect the call to us. So it's okay for the call to go somewhere else. But if your call has an area code for Harris County or Houston or any of these other, 30 some odd area codes that we serve, then it'll come usually to my shop. And we have a backup center inside of the state as well. So there's about 220 centers across the US. There are 5 call centers in Houston that take the calls. I'll get you in just a sec. In Texas, we answer over 11,000 calls a month for 988. We answer about 82% of those right here inside of Texas. But the really cool thing about 988 is if we're all busy, it'll just answer by one of our friends. We're a backup center. So all calls are answered. And right here in Harris County at my shop, we take over 50% of those 11,000 calls. So super busy. So we're taking about 5,000 some odd calls a month. Yes, sir. Hi. In my center, it's about 10 seconds. Nationally, it's about 32 seconds. Great question. Yes. Oh, sorry. The first question was, what's the wait time? So I answered that. And the second question was, so are there people available 24 hours a day? Yes. 24/7, 365. So let me see if I have that on my slide. Nope. So I have about 95 staff that work on this project. And so they're always there. And our busiest times are evenings. So if you were to call right now, I think I probably have 16 or 17 people on staff right now. Yes, they work shifts. It's 9 to 5, 10 to 6, 11 to 7, 12 to 8. They can have a choice. So thanks to our good friend COVID. Prior to that, it was all office-based. I have a beautiful, super empty call center now. But so my staff can come in, always welcome to work in the office, but they also have the ability now to work remote. Mm-hmm. And we can hire from anywhere in the state of Texas. So which is also nice because we cover a lot of the state. So you don't have to live in Houston. Okay, so I know we're trying to. So what can you do, right? Because as you've been sitting here listening to all this stuff, it's like, ugh, womp womp, right? This work, that's welcome to social work, y'all. The work never ends. And there's no matter what your issue is, there's work for you to do on it all the time. So what you can do, I'd love for you to follow our organization and some of my programs on our social media, like and share, and subscribe below. So I'd love for you to share the community training information that I told you about. Make sure that now you know and aware about 988, share that with some folks. And then, kind of like we've all been talking about, just be nice, right? Like be empathetic and kind in your daily action because connectedness is key. Right? Connectedness is a huge part of suicide prevention work, and it works. The other thing is that you can download oogads of free stuff about 988. So if you work for an organization, if y'all are doing your internships or placements, get this. You've got a print shop or something at your work, you can print cards, you can print posters. There's all kinds of cool free stuff out there. So please use it. And here's our contact information. I'm assuming that this will be shared so that y'all can have it later. So if you live or work or know people in any of our partner zip codes that I mentioned before, please reach out to us. We're always trying to build those relationships. If you want to know more about our training, please let us know. Follow, like, and subscribe. We talk about all kinds of events and things that we're doing in the community all the time. So despite sort of the scary, yucky numbers that we've talked about today, everything that you do every day to practice kindness and compassion, everything that you do to work toward an equitable and just society is suicide prevention work. You are doing that work. You don't need a special training. You don't need fancy letters behind your name. You don't need some kind of certification. You just need to be a good human and a good neighbor, and you're doing good suicide prevention work. So pat yourselves on the back, because I'm assuming that because you're here at 7:45 on Monday night, that you're already checking off some of those boxes. And we appreciate you because we can't do this work without you. So once we're all on board, those numbers will drop, and we'll do something else. I don't know what. All right.
So thank you both, Jennifer and Dr. Gehring, and of course, Dr. Savani and Dr. Cherding, if you are still on and you can hear me. Before we wrap up, I wanted to give everyone an opportunity to ask questions of our panelists. Does anyone have any kind of question about anything that was presented tonight that you weren't quite sure about, you think you want to ask? Now's the time. Questions? Don't be shy. Okay, I'm going to come around the room. Okay, you're going to go around the room. Okay.
First of all, thank you so much, particularly Jennifer. I just feel inspired by you every time I hear you speak, and I really appreciate you. And I appreciate your connection to our institution and our program, and we hope we keep you and for a long, long time. And so I think, and Dr. Gehring, this may be, help me here, and Dr. Savani, the global sort of reporting of suicide, is that way underreported? Or I know in the U.S. we have, or in other developed countries, better mechanisms, and you're being very creative. I mean, what do we really kind of think that looks like, and when is or what are the efforts to really to elevate this sort of phenomenon that, yes, it's in developed countries, it's suicide is what it is, but globally, it connects so much more to justice issues, to low income issues, and equity issues globally. I don't know, is that conversation happening? And then, but yeah, I'd like to some sense of really what you think the numbers might be worldwide.
It's really underreported.
So for India, it's 20% underreporting. Those are the estimates.
Okay, so we're saying in India, it's 20% underreported, and Dr. Gehring, you're saying it's also underreported.
I'd be willing to double the number. Based on, it's hard to know this because nobody wants to do prevalence work. And no government wants prevalence work to be done. Yeah. I think in the US, our numbers are underreported. Our medical examiners are great. But there's a lot of reasons to underreport things.
So even here in the United States, there's underreporting. And you're saying the reason for that is primarily what?
I didn't say there's a reason. There's multiple reasons. You talked about inequality. We do know that gender inequality is a huge source of suicide around the world. That's clearly underreported because it's not an issue that wants to get a lot of attention in many areas. And it is an issue here that gets underreported. And that doesn't bring into consideration a lot of other issues where people and families and communities are quiet.
Okay. Any other questions?
Thank you again all for this amazing presentation. I was really surprised by the comment made by you that a lot of parents don't even know that their kid is having suicide ideation. And as somebody who works in education in schools, I want to know, what are the main risk factors of suicide ideation within adolescents and kids? And second, what are some practical tips on promoting connectivity, empathy, and kindness within a school setting?
Do you want to start with this? Dr. Savani said this earlier. You can have all the risk factors, and I can list out dozens of to you. It doesn't mean you're suicidal. And you have none of the risk factors and be suicidal. What we're saying is you have a greater risk or propensity for that behavior. Have you some of them? So certainly the largest one that's 3 or 4 times more powerful than any of the risk factors, prior attempt. So prior attempts are the largest. Depression would be the second. That's usually twice as powerful as any other. But you can go down the line. Parental substance use for generally that's for a male parent. For a female parent is more depression. There is involvement with the law, lower grades, isolation, less friends. LGBTQ is distinctly very, very, very high. And it's not that there's any genetic or research that says if you're in the LGBTQA community that you have higher risk. You don't. It's from the loving friends and family around you and how society treats you. So there's a number of risk factors that we've clearly established for young people, as well as other age groups. And it just gets really concerning. And a lot of times parents will minimize things. Oh, you're just going through things. And what do people do in high school? Like, you want to be normal. You want to fit in. You want to just get along with, and who here would go back and do high school again? Even for the popular kids, high school is often hell. It's a very challenging time. And during that time, if you stand out in any way, oh, you're thinking of suicide. What's wrong with you? And my thought is nothing. More than half will. Only, if 10% of people have blue eyes. Blue eyes didn't exist until 9,000 years ago. That is an aberrant. We should be after people who are blue-eyed, not people who think of suicide.
And also normalize that it's okay to have thoughts of suicide, right? So that it's not, like you said, it's not weird. It is normal, especially if you're a young person, when you are looking at climate change being like a reality of your world, right? When you look at the impacts of capitalism, when you look at the impacts of, again, like oppressive systems, it is completely, absolutely normal for your body to reject that type of inequity, right? So when we talk to kids who are experiencing what we think is a very rational response to living in a very irrational place, we're not trying to convince people that thinking about suicide is wrong. What we're trying to do is kind of like what we're doing here, which is like add some hope building in, saying, you're right. Like, these are very difficult things to think about, and we need you. You are part of the solution. You are part of what makes the world a better place. Like, you are worth our time and our attention to try to figure out, how do we get to a more just and equitable society? So that's how we talk about it. And then with the parent piece, we talk about change in behavior, really, and the challenge with youth suicide work is that a lot of the things, like Dr. Gearing said, the risk factors are also just sort of like being a teenager, right? Like, I don't want to talk to you anymore. Like, no, I don't want to hang out. No, I don't want to do the sport that I've done for the last 10 years, right? So a lot of it is just people growing and changing and evolving and hormoning. And so it's kind of hard to yeah. And so it's weird when but as parents or not just parents, but adult people, and their friends, honestly, like the best people to help people or peers, is just, again, being aware and taking people seriously. I have that's my son out there. So if anybody wants to know what it's like to live with a person that does this work, please feel free to talk to him, because there is no offhand, I just want to die, or I just want to kill myself, which is pretty normal language in kid land. But if you ever say that around me, I'm going to be like, tell me about that. Right? And it's okay if you feel that way, but I want to know what that means to you. And so, when we, so it's about talking, and it's about having open dialogue. So you asked about communication and empathy and kindness. It's just that. Don't be weirded out when people want to talk about hard stuff. Just kind of be like, I feel so honored that you want to talk to me about that. I know that must be really hard to say. Tell me more. My favorite thing is tell me more. Tell me more about that. And then when you're done, you can walk away and be like, oh my God. Right. And that's okay too. But in the moment, you're chill, right? You're chill. You want to encourage that conversation. You want to encourage that connection as long as you can keep it. And that's, if you were taking my crisis intervention class, we talk about this apex moment of the crisis, right? Because we know time and distance saves lives. We all talked about means and mean restriction and the pesticide housing facilities, critical behavior, gun locks, critical behavior, medication pouches, critical behavior. Because if we can help somebody work through that apex moment by being compassionate and being kind and having access to a thing, a text, a phone, a call, a friend, a neighbor, whatever, we can get through that. It's that. Anybody in here volunteer for crisis text line or anything? Best, right? So going from a hot moment to a cold moment is the best thing I've ever trained in my entire life, right? It's that hot moment, get past it, and then we can do the work. But we can't do the work until we get you past that moment. And that's where that connection is key. So people who isolate, that's critical, right? So, parents and adults, if you haven't seen your kid and you haven't had a chance to talk to them, that to me is the scary moment, right? Because I just need to connect. I need to see you. I want you to do your homework in the living room, right? Don't be locked away. And you're I don't want to do that, right? And their head spins around and it's oh, thing. But that's part of the, that's as much as they might complain or be it's a connection piece, and they'll recognize that for what it is usually. Sorry. Okay.
What is the appropriate age as a parent to start talking to your child about it?
Always. Sorry.
I was going to go anytime, but
always.
At 2 years old? I'm going to talk to my 2 years old.
Absolutely. Because, what you're talking about there is you're talking about love, kindness, genuineness, compassion. So, it's okay to be sad, but now we're going to also work on how do we, the words, the language. There's a lot of cool tools out there, like feeling wheels. If you ever worked with feeling wheels, really neat. Because just being able to talk about feelings is huge. Like, and so there's a really cool training that's done even for elementary kids through American Foundation for Suicide Prevention called More Than Sad. And then based on your kid and your connection, you can determine when is it that you, and honestly, y'all, there's so much media now, like TV shows. So if you see something weird, like in a TV show that you're like, oh my God, like not weird, but like, you're like, I can't believe we're watching this and I'm going to try to ignore it. Do not ignore it. Whatever it is, sex, drugs, rock and roll, sex, drugs, suicide, mental health, beautiful teaching moments. Do not go past it. If you see somebody like having like a healthy sexual relationship in a TV show, being like, oh, that was a really healthy interaction they just had. Like they look like they really love each other, right? Same thing like suicide, like, oh, wow, it looks like this person must have been feeling so overwhelmed that they made a choice to try to, it depends on age. For little kids, you can say hurt yourself. For bigger kids, you always say they wanted to die or they wanted to kill themselves, because little kids don't have an understanding of permanence of death. But that's a whole nother. But so yes, all the time, start and just, your kids or the kids that you're around.
And the only thing I would add is talk all the time. They've done several studies on when someone actually makes a decision, okay, I'm going to end my life now. Half of them within 15 minutes. 48 to 52% will do within 10 to 15 minutes act. And it's not like that they're impulsive by nature. It's just that once they reach that point, then they do something. So the idea of removing means or having a 15, then the crisis inherently is time limited. But if you can have someone to talk to and say, normalize that, yeah, it's okay to feel crappy and to feel lonely. And if you compare yourself to social media, that's, I don't know how to say evil nicely, but envy is one of the 4 traits that scare me as a clinician, because it erodes happiness. And that's what you look on social media. It just is designed to create, look what you're not. When the reality is that's what you are. The average American has 2.1 friends, down from 2.3 friends 25 years ago. But anyone you can talk to is a great thing at any time.
Did you have your hand up earlier?
Hey.
Sorry, I have a quick question. So I know for your stats, you put that the main one was poisoning and the second one was OD. How do you know when it comes to OD if it's like suicide, like they chose to take their life with OD, or it was just by accident and or would that technically still count as suicide? Not you being mindful, like not in that way, but like,
So if I heard your question, that is, how do you delineate between an overdose versus a suicide? Good question. Let me put in context. So that Dr. Anish Cherian was sharing about India. In the U.S., the gun rules the day. 49%, 54 of deaths are by gun. But certainly overdose is high, poisoning is high. And they do a lot of work to really understand if somebody was regularly using drugs. Drugs is a common thing that they were just trying, or did they just tip over the edge versus, were they despondent, they hadn't used drugs, there is some blurring between the two to say that it's not, but there is a lot of ways to really be clear about when the medical examiner looks more closely at this. This was an OD versus this was a suicide. That being said, the blurring between that two is significant. And think about if you're a family or a partner, or if you have certain faiths, even though a lot of them have changed how they view these issues, it's easier to say it was an OD than it was a suicide.
An accidental overdose.
Yes,
that's the point. That's the language people want to use. And so a death by toxicity for a suicide death is very scary for people. And so, And so there's training. So the American Association of Suicidology suicidology actually has a training on basically psychological suicide related autopsy is what they call it, which is it helps train medical professionals and medical examiners, justice peace, people that make those differentiations around these kind of really difficult decisions, because they're receiving pressure often from families around how to name these deaths. And so, which is why we talked earlier about what a critical role those folks play in our community as far as helping us get factual data so that we know how to help serve communities. Some of that data, I'm going to get you a second. Some of that data I shared by our neighborhoods. Stephen had asked a really great question about like, what are we looking at? We have some of those neighborhoods, especially the ones that had like 9, 10, 11, 12, 14. We had some neighborhoods where it's like almost exclusively firearm, but there was one neighborhood where it was exclusively hanging, which was really interesting. And so again, like if I had a research team, that's where I would be like, this is fascinating, because like that is not a usual thing, but trying to kind of figure out like what it is in our communities is really helpful to us doing prevention in the field. Right? Because if we're going into these neighborhoods and we're going into these communities, it really, people are talking, everybody knows, right? So how do we help with means safety, right? So when we have conversations around, like I said, gun locks and medication bags and stuff, how does it help us learn so that we can help people be safer?
So this is not a question for So, part of the problem, one of the factors that it could be is the stigma there. I mean, I've heard of friends whose parents don't believe in mental health. They just think it's like a slap on the wrist. So I think that's part of the problem is if we don't address the whole umbrella term of mental health, then there's also a lack of therapy and people feel like they can't afford it or they don't have the resources for it, which causes them to have these suicidal thoughts because they don't have the family members or the friends to confide in, or they just can't get the services that they need to not feel that way.
What was your name?
Isabella.
Isabel, that was a brilliant comment. And you're very right. If we started treating suicide like a heart attack, we would be doing a lot better. Because what we're doing is, unless you show up in the ER, we don't want to talk to you. But if you think of cardiac, if your heart is not feeling well, you know what to do. You know the symptoms. We hear it everywhere.
And
It's
there are, like,
common.
events
It's
that
human.
lead up to this moment. It's not
Having a heart attack doesn't make you less of a brilliant, wonderful, caring, compassionate human. Yet somehow the idea of having a mental illness does, which is just awful. And so if we could think of like, oh, you know what? I've been feeling down for a week or two. I think I just need to give Jen a call and see if I'm feeling a little better, do a little checkup on my mental health, like you would go to a doctor over a flu. And that there's a lot of work to do. There's a lot of areas. And it is a significant barrier to access and mental health and care, and how people communicate and talk about it in communities of faith and families and neighborhoods.
if you live with parents who don't want you to go to therapy or something like that.
Right, because they might see it as a perceived failure instead of a perceived humanness. Now, I will say on top of all that, we have the access issues have a lot of issues related to larger oppression and racism that exist in the system as well.
Yeah, absolutely. And just to add back to your comments, like you said, and obviously I pointed to my friend when I saw the statistics of Spanish speaking is 60%. Obviously, it's higher. One thing, I'm a Hispanic woman. My parents are Hispanic. They didn't believe in mental health. I was always crazy, but yet I broke the stigma by going to therapy. And that's what I'm doing for my kids now, is that they go to therapy, we talk about it. So how are you guys, or in specific, these area codes that you saw, because I live in those area codes, how are you helping the Hispanic community? Do you have workshops for them? Do you have people running out on the streets, knocking on doors? Hey, we have a workshop. And how can we help as well to volunteer, since we are Spanish speakers and that is our community?
Woohoo! Yes. So first things, like kind of like us, so follow us, like, and know what we're doing in the neighborhoods. And so like we have these like learning circles regularly in all of our neighborhoods and listening circles where we're hearing from the communities, what do you want? What do you need? But we're not going in going, we're here to do a suicide prevention training for you today. Absolutely not. And you know, the name of our project is Healthy Minds, Healthy Communities. It doesn't say the Harris Center for Mental Health and IDD at all. We're completely separately branded for all of those reasons. Now, are we a little sneaky with what we do? Of course. So we're bringing in all the materials and information, but we understand that the language that we use can already not get us in the doors where we need to be. And so honestly, like I said before, like we come in with lunches and dinners and like go where the people are. So one of our favorite things, like at Doss Community Center over near Aldine, they have like a great community center, and the ladies, the Spanish speaking ladies there, love Zumba. So we try to make all of our presentations after the Zumba class. And so one day when I noticed that was happening, because we had brought in like cookies and pizza and stuff, I was like, I'm going to a store. I ran to Fiesta and I got carrots and hummus and oranges and stuff, because I was like, these ladies are all about like, well, they're working out. Like they don't want to come in here and eat cookies and pizza. And so like, we were kind of like, what do they, and I was at that one just because it was one of our first ones, but I don't usually go. Cause again, like I'm not a Spanish speaker and I don't look like the neighborhood. So like who wants me there? So yes, but are we desperately in need of people to not just volunteer, but like come work for me and get paid to go out in the community, right? Like, yeah, we're hiring people, especially people, again, from the neighborhood who speak the language. Like that is a critical moment of our success. So yeah, hit me up. That was my email.
Just don't tell the advising department.
So we're gonna wrap up. I want to say that I think obviously the work that you folks are doing is critical. I think I agree with Jennifer that the best way to do it is by being kind and compassionate and everywhere. And that's such a cliche sometimes, but it really does make a difference. I think we really do have to be kind and compassionate in every area of our lives, at work, at home, with strangers. And I don't know, I just lost my train of thought because I guess I'm getting older. But anyway, I'm having a real senior moment. But anyway, thank you all for being here. You know, I know what I wanted to say. Isn't it interesting that I know that not everyone can come on a Monday night, but in a community, a UHD community of 14,000 plus, how many people do we have in the room? How many people did we have online? Not a whole lot. So it is not an easy topic to talk about. And I really applaud you folks for doing the work that you do. Because, you know, people struggle. We struggle. I struggle. I mean, you know, it's hard. We've been through a hard 3-4 years. So be kind. Be loving, be kind towards one another and yourself as well. So Oh, yes. If you could, please snap that code and take the survey. It'll take you a minute of your time. Be kind and take the survey, please. All right. And thank you very much to Dr. Cherian for being up at 4:00 in the morning to be with us. And thank you to Dr. Savani, who really is the one who spearheaded this whole thing.